Good afternoon, everyone. My name is Michelle DiFrancesco from Simplifying Media, the parent company of the HR Daily Advisor and the HR Employee Benefits Week. Thank you so much for joining us today. We have a lot of great content to share with you during today's session, which is entitled Manage Diabetes Risk and Cost in Your Health Plan, Tangible Ways to Lower Costs While Also Improving Care. Sponsored by our friends from the Diabetes Leadership Council. I would like to send a very special thanks to our session sponsor for helping make this event possible. And if you do wish to learn more about the Diabetes Leadership Council, you can visit the resource widget on your screen for some more information, as well as for a great resource that you can download for free provided to you by our sponsor. So definitely check that out. I do want to cover some housekeeping items. And to get started, the console that you're looking at right now does offer a few different application widgets that you can use during our session today. The most important is called the Media Player widget, and this will allow you to control the volume of today's session. Please take note that there is no dial-in number for our attendees, and the audio is streaming directly from your computer speakers, so please be sure they're turned up and on. You don't want to miss any part of today's session. However, if you do have to step away or if you miss any part of our program, we are recording the entire session and we'll be sending it out to you via email in about 24 hours. Today's session has also been approved for HRCI, SHRM, and HCI recertification credits, and we'll announce at the close of today's session how you can obtain your credit information. If anyone on the line today experiences any technical difficulty, please feel free to let me know by using the Q&A widget on your screen, and I'll be happy to assist you. And speaking of that Q&A widget, we're really excited to hear from you today. And we're going to be hosting a live Q&A session at the end of this presentation, so I hope you're okay with questions for our speaker. You can go ahead and submit any questions at any point throughout our session by using that Q&A widget that I had just mentioned, and we'll get to as many as we can at the end. Also available today, we may be asking you some questions in the form of polls. So when you do see a question pop up for you, you'll be able to submit your response right in the center of this screen where the slides are currently. So keep your eyes open for some of those poll questions. All right, let's get into some introductions today. I'm really excited to welcome our guest speaker to the floor, George Huntley, founding member and CEO of Diabetes Leadership Council and its affiliate, the Diabetes Patient Advocacy Coalition. Now, if you do wish to learn more about our guest speaker, George, you can see his full bio in the speaker bio widget on your screen. George, thanks so much for being here today. I'll kick it over to you to get started.
Super. Thanks, Michelle. I appreciate it very much. Good afternoon, everybody. I appreciate your spending your hour with us and learning more about diabetes and how to hopefully lower your risks and costs in your health plan on diabetes. I am George Huntley, as Michelle indicated. I am the CEO of the Diabetes Leadership Council. I'm also a patient living with type 1 diabetes for over 40 years. I'm a past national chair of the board of the American Diabetes Association. And in my other day job, I'm the chief operating officer and chief financial officer of a professional services firm based in Indianapolis, Indiana. In that role, I have been and am still the plan administrator of a self-insured health plan for over 25 years. So I've been in that, I do still manage our plan and have the understanding of what I get and what I don't get in that regard. So very quickly about the Diabetes Leadership Council. We are all former leaders of national diabetes organizations who provide policy expertise for lawmakers and advocates. We are a policy shop and an advocacy organization. That's all we do is advocate. We don't do patient services, et cetera. We're here to improve access and affordability and care for people living with diabetes. As Michelle mentioned, we are affiliated with the Diabetes Patient Advocacy Coalition, and the two together are really the powerful engine, because the policy advocacy out of DLC then gets amplified by thousands of grassroots advocates in the Diabetes Patient Advocacy Coalition, so that we can make that policy actionable so that the patient voice is heard. And through things like today, we help educate employers in addition to lawmakers and the advocate community itself. So again, happy to be here today and appreciate your time. What we're going to cover is diabetes basics. We're going to ground everybody to make sure that we all have a understanding of what diabetes is, what is this thing, how much does it cost? Answer, spoiler alert, a lot. Innovation, what's going on, what's new in that world, and what's coming from a care perspective that we need to be thinking about in our plans. We're going to talk about some marketplace dynamics that are influencing the costs and driving some issues within our plans and some of the players around that, and talk specifically about some plan design options that we hope you'll consider in managing risk and really improving care at the same time, which is the good news here is that both of those are not mutually exclusive goals. And as Michelle mentioned, if you have questions, please put them in the Q&A. We will try to get to. I'll try to get to them as we go, or certainly at the end. I'll hope to have a few minutes to cover those. But don't hesitate to pop a question in there. You're not bothering me, and I will try to keep an eye on it and to see how we go. So, what is diabetes? Yeah, it's a lot of people have it. 40% of Americans, 40% of the country has either diabetes, which is 37 million of us, or pre-diabetes. That's a lot of people. So everybody knows somebody with diabetes. Diabetes is an issue that raises that it basically high blood sugar. It affects how the body converts food into energy. So if you think about the food that you're taking in and you're eating, whichever you had for lunch, that lunch needs to digest and then turns into fuel in your bloodstream, really by way of glucose. So that turns into fuel in your bloodstream. And if you have diabetes, you're not using that fuel very well. So you're converting it and it gets into the bloodstream, but it's not getting out of the bloodstream into your body to provide you the fuel that you actually need into the cells and the muscles. It is recognized as a disability under federal ADA and IDEA laws, easy for me to say. There is no cure yet, and we're going to talk about some innovations and some things that are reshaping this landscape as to how to manage this disease. So we're making progress, but when I was diagnosed in 1983, they told me it was going to be cured in 5 years. I'm still waiting for that day, but in the meantime, there's a lot we can do to manage it. So let's talk about, insulin being the key to diabetes, and I'm talking about the blood sugar that's in the cells. As I mentioned, you've eaten your lunch, and it's now been digested, and it's all going through your veins, going through your body, but it's not getting to your muscles. Insulin is what unlocks the cells and allows that sugar to get into that fuel to get into the body so that you can grow, live, thrive, etc. In type 1 diabetes, which is an autoimmune disease, and it's the smaller percentage, your autoimmune system attacks your pancreas and eliminates your ability to make insulin. So you have to take it via an injection via an injection or a pump. 90 to 95% of people with diabetes have type 2, which is a metabolic disorder where you are not using the insulin efficiently. So you may be deficient, you may not be making enough, or you may be resistant to the insulin you are making. And that's very common. 1 in 3 adults with diabetes are on insulin today. So you can tell that a lot of type 2s are taking insulin. It's a progressive disease. And so when you think about someone being on insulin, many of us think about type 1 diabetes. More people with type 2 diabetes are on insulin than type 1. It's just that 100% of type 1s are taking insulin. But there's a lot more in the population of type 2. So as we're thinking about our health plans and the coverage of these things, it's really important that the people with type 2 are getting the access to the things that they need as well. I'm going to move us forward. And why do we care about this? Because it's chronic and it's progressive. So we say there's no cure, but we can prevent or delay these very serious complications: diabetic retinopathy, blindness. It's one of the #1 causes of blindness. Heart disease, 2 to 4 times more likely to die of heart disease or stroke. It's one of the biggest causes of kidney failure. If you go to a dialysis lab, you're going to see a lot of people with type 2 diabetes and with diabetes. The #1 cause of non-traumatic amputations, lower limb amputations, because it impacts your vascular system, both micro and macro, and it damages your nerves. So people walk around with a sore, there's been construction workers with nails in their feet. They didn't even know they had it because they couldn't feel them. The point here is all of these things, that's where the cost drives from. It's the heart attack, it's the stroke, it's the dialysis, it's these amputations, and then supporting that thereafter, where you've got serious cost to your health plan, and that's where your risks, come into play. The other bad news here is that it's disproportionately impacts communities of color. And you look at the Native American, Alaskan Native, you've got the Hispanic, the non-Hispanic, Black. Some of these communities are hit almost double the incident rate of the non-Hispanic white communities. And these communities of color are less likely to be prescribed a continuous glucose monitor, which I'll talk about in a moment, be prescribed an insulin pump, get diabetes education, have access to these newer things. These communities are less likely to get the help that they need. Therefore, they're more likely to develop the complications that we just talked about. They're more likely to be frequently hospitalized for severe high or low blood sugars. They're more likely to be hospitalized due to COVID-19 or die from it. So it is a very expensive and devastating disease, and without the tools, these complications get worse and are more likely to hurt your plan. Now, why is diabetes so hard? People, if you don't live with diabetes, you think all I have to do is eat right and exercise, and this is easy. And unfortunately, it's not easy. There's a reason why everybody struggles with diabetes. It is 24/7, 365, and whether you're type 1 or type 2, the difference is how you have high blood sugar typically. The difference is how did you get there? But the factors that are impacting your blood sugars are varied. So what food are you eating? You can see on the left-hand side, the carbohydrate quantity, how many did I eat? How fast is it going up? And then over time, what happens to it? So fat will slow down. It really doesn't do much to you, but it slows down the absorption of your carbohydrates. So if I have pizza or something with a lot of cheese on it, pizza's got a lot of carbohydrate. It's not going to, which would typically spike your blood sugar, but the fat on it's going to slow down the digestion and the absorption of it. So the timing of when you take insulin is important in that for a type 1 and a type 2 if they're on insulin and they're taking meal-based insulin. Caffeine, protein, all of these things are impacting a patient's blood sugar. What medications are they taking obviously is going to impact it. If they're on a steroid, it's going to go up. What are they doing activity-wise? Light exercise will lower your blood sugar. High-intensity exercise will lower your blood sugar and then will raise it because you're under stress. If you're doing high-intensity exercise, you're eventually stressing yourself. So it has a counterintuitive scenario of I went low and now I'm going high and my blood sugars are going up. The same is true with just behavioral stress and the stress that you feel in daily life from family and social pressures can raise your blood sugars. Too little sleep will raise your blood sugar because, again, your body is stressed. No 2 days are the same. A patient with diabetes and with any chronic disease, if any hopefully folks out there are fans of the Broadway musical Rent, where you have 525,600 minutes, 525,600, whatever it is. I'm not going to sing the rest of the song, but there's 525,000 minutes in a year, and a patient is lucky to be in there with their healthcare provider for 120 of those minutes. So the patient's on their own dealing with all of these factors, and it behooves us as plan administrators to give the patient what they need to make the right decisions, to make the decisions that keep them out of the hospital. So hopefully that message is getting through. This is not simple, and no 2 days are exactly the same. So let's talk a little bit about the cost of diabetes. Again, it's expensive. 1 in 4 healthcare dollars from 2017. I think the pandemic probably slowed up the next publication of this. This data tends to come out every 5 years, but I think it got slowed down. It's a top 4 health plan cost driver. Everybody in the audience here watching this knows that. You don't need me to tell you it's a big driver of your plan. The issue is we're spending the money the wrong way, and I'm going to touch on that again in a second. But we're spending the money on complications versus managing the disease. And insurers report they're spending $30,000 per year for somebody with complications. This shouldn't shock you, versus $10,000 or less if somebody doesn't have complications. Diabetes is expensive, but it's a lot more expensive if they also have kidney disease, heart disease, and some of the other things that come along with it. And here again, we're spending on the wrong things. We're, hospital inpatient care, prescription drugs to treat the complications versus managing the disease itself. It's $327 billion annually in cost in this country. But in addition, it's got reduced productivity. How many people are not coming to work because they're home, they're not well? What productivity does that cost your company as you're trying to produce and provide a service? There are a lot of intangibles that happen when one of your employees is missing, or their child or a loved one is sick and not getting the care that they need. This slide I like and don't like at the same time, because this is sick care versus health care. This really shows how poorly we are doing in this country. This is a cohort of 37 million Americans. 37 million of us have diabetes, diagnosed diabetes. Those 37 million people drive 16 million ER visits a year. That's insane. If you think we've got diabetes licked, look at your ER visits. Of those ER visits, about half turn into an inpatient hospital stay. That's also really expensive, and that's where your costs are. These 2 boxes, I should have had those be red and the bottom ones be purple, because those are red flags. And we're not reaching our goals. We're not reaching our health goals. Less than 1 in 5 meet the A1C targets, blood pressure, cholesterol, and non-smoking. 89% are dealing with overweight or obesity. We've got a lot of room to improve as a country, and that it's your employee population as well. So let's talk about what's going on from an innovation perspective. Of the last few years, we've seen a lot of things that have been tools that are now available for those fortunate enough to have coverage for it. So the standard of care is now aimed to equip the patient with what they need as a dashboard. I'm a finance guy. I like to talk about what gets measured gets managed. And here on the left is a graph depiction of a patient's blood sugars throughout the day. And what you really want is tight time and range. These green bars there, that green section, that's where you really want the patient to be. And you want to be 70% in range. When you are outside of range and when you're having this roller coaster ride, you get worse health outcomes. It's not very pleasant for the patient, and it's more expensive. You want to be over there on the right. Now, that's a really nice graph on the right, but it is very possible with today's tools to spend most of the day in range with the tools that are out there today, especially with a patient on insulin. So the whole goal here is the way you live, the way you feel when you're on that right-hand side, words can't describe how much better that person feels on the right than the one on the left. And what are these technologies? So glucose monitoring is probably one of the biggest breakthroughs in the last 10 years that have happened. They've been on the market for a little while, but they're better and better and better. They give a reading of blood sugar every 5 minutes instead of a finger prick 2, 3, or 4 times a day. You're getting 280 data points. So you really can see what's happening. You can see the impact of the food you just ate. And you know that not only right now am I at this level, but it also is going to tell you whether you're going high or low or whether you're stable. So you know what direction things are moving, not just that one data point in time. And that is very, very valuable information. And we have a lot of studies where a patient, even a type 2 patient, gets access to this data. They make better decisions because the numbers don't lie. It's not the nagging spouse. It's not the doctor. The numbers are staring them in the face. They don't lie. The insulin administration that goes along with it, now the insulin pumps are talking to this continuous glucose monitors. And these glucose monitors and the pumps talking together, now you have smart pumps that are turning off if the patient is going low, will give a little bit more insulin if the patient is going high. And you get a much better, much smoother ride, a much longer time in range for that person, and lower complication costs. The other comment that I would make here with these connected delivery systems is that it's personal. Technology is personal. The user interfaces are personal. They cost about the same, whether it's one company's CGM or another company's CGM, or one insulin pump versus another insulin pump. But the patient using it, they've got a very personal interaction with that device, trust me. When you look at your parking lot, you do not have all Chevrolets or all Fords in the parking lot. You've got a variety of cars. They all take you one place or the other, but you've done it based on personal choice. These technology choices really are personal. Make sure your plans are covering the spectrum that's out there and not limiting it to one pump, one device. You're not going to get as favorable a health outcome if you are limiting it, and the cost difference between the two are minimal. So I'm going to move to a poll question right now. In a recent study of 571 people with type 2 diabetes, what was the financial impact of using a continuous glucose monitor? So 571 people with type 2, not type 1. These are type 2 people with type 2 diabetes. Did it cost the plan $424 a month? Did it cost $53 a month, almost break even? Did it save $53 a month, or did it save $424? So if you would, just please, these are guesses, I get it, but what do you think is happening there? I'll play the Jeopardy music in a minute while you're doing this. I would urge you to please, click on a few things here. Give it a second. It's always curious as to how people guess on this and what people think it's going to be. All right, I'm going to close this out. So 17% thought it was going to cost $424, and everybody else thought it was going to save money. With most of you figuring out it was going to be almost 59% thinking that it was going to save $424. Well, congratulations, the 59% were correct. It would save $424 per month if you provide people with type 2 a continuous glucose monitor. And those were driven by reduced inpatient hospital stays. That patient sees when they're dropping low, they see when they're going high, and they can take action that they otherwise would not have taken, and they stay out of the ER and they stay out of the hospital. These things are substantially cheaper than a hospital stay. So thanks for playing along. I appreciate that. Let's talk about some other things that are out there now. New glucagon rescue options. So glucagon, think of this as like an EpiPen for someone having a low blood sugar. If you're having a low blood sugar and the individual is passed out, there are now new glucagons available on the market that are like an EpiPen, where it is just you inject the person with the glucagon. The old ones had to be mixed during the emergency. The glucagon did not used to be stable enough. So you actually had to mix them during the emergency, which is really hard to do. Now you've got them where it's just a pen, or it's an inhalable. As long as the patient is breathing, you can pop it up their nose and they can do it. These are better options for emergency intervention, and also something that if your plan should be covering. If you have somebody with diabetes that say, hey, I can't get these new glucagons, there's a reason they should have them. And again, it's a lot cheaper than going to the hospital. New obesity and type 2 treatments are out there. A lot in the news on these issues. These new drugs treating type 2 diabetes and obesity are very effective. Your patients are losing 15% of their body weight or more, in some cases 20, and it's really helping to lower their blood sugars while this is happening. So that it's managing type 2, and it's also helping them lose weight and managing their obesity. 97% of dieters regain their lost weight. Obesity is a disease. We're going to touch a little bit on it as we go here, but let's talk about it for a second. Obesity is a disease, and just like diabetes, it has complications, and the long-term complications of obesity are as bad or worse than the long-term complications of diabetes. You're looking at cancer, you're looking at heart attack, stroke, a lot of the things that are happening in diabetes happen in obesity. They are all linked. When we think about what the dieter, you say, oh, they just need to lose weight. We need to move from blame to biology. And these drugs are hormones. This is hormone replacement therapy. That's really what's going on here. And so with a hormone replacement therapy, the patient needs to replace these hormones that are in obesity getting blocked and stopped and not happening, not getting produced. And that's the science behind what these new drugs are doing. And there's going to be more and more of them coming out over time. All right, so let's talk about some other marketplace dynamics that are going on here. Insulin is the poster child drug for what is unaffordable out there. And if you look at this slide and that top line, that's list price of insulin over the past decade. It went up 143%. The net cost of insulin, the net price of insulin for your health plan has dropped more than in half over that same period. So the list price that the patient's paying up 143%, the net cost dropped more than in half. And that difference, that delta that you see widening gap, represents rebates. Insulin rebates are over 70% now. And the average rebate as a whole is 48% on all branded drugs. So give any drug, doesn't necessarily need to be diabetes, any drug out there that's a branded drug, not a generic, has a rebate on it. And again, on average, it's 48%, which means the plan is paying half of what the patient's paying, or the patient is paying double what the plan is paying for it, typically during the deductible period. So we're going to talk about that. And let's look at the players in this system here. So we've got the consumer, which is your employees, the participants in your plan. They are paying a premium, and that goes over to the insurance company, or you're as the employer, a self-insured employer like I am. And so you get that premium from them, and typically through their paycheck. And so they're paying a premium to get access to the plan. They're paying, I'm joined Sam's Club, but when you come to drugs, they're not getting Sam's Club prices. You're not giving them the access to that. They're then, during the first quarter, they're going to the pharmacy, they're going to buy their drug, and they got to pay the deductible at that point. Or if they're past the deductible, they're in a copay, which is typically much more manageable. So the pharmacy gets in a vial of insulin, the list price can be $300. That $300, the pharmacy takes a piece of it, and let's just say $275 drops over to this drug company. The drug company then sends about 225, and these are round figures, guys, but the proportionality of it's pretty accurate. So of the 275 that landed at the drug company, 225 went over to the pharmacy benefit manager. That's Express Scripts, CVS Caremark, Optum Rx. I'm going to show you that in a second. These guys now have $225 of your participants' money that when they are in January and buying insulin or their drugs. And again, these proportionality of this doesn't matter what drug they're buying. They're keeping, the PBM is keeping a piece of this and sending the balance of it back up to there. Many of you don't know how much they're keeping. On record that we have from some states that are requiring transparency, we specifically in the state of Texas, we know the PBM's hanging on to about 10 to 13% of the rebates on average, and then the balance is moving up to the health plan. You then are keeping that health plan, those rebates, and you're saying, oh, I'm going to keep these so I keep the overall plan costs down. And so now, congratulations, we have the sick who subsidize the healthy, which is the exact opposite of how insurance is supposed to work. So we've got a broken system that's at play here that we all need to wake up and understand what we're really doing. I'm going to talk a little bit more about the economics of that in a second. Where the money goes and who are the players, the pharmacy benefit managers, these three here, Optum Rx, CVS Caremark, Express Scripts, they have 80 to 85% of the US drug market. They are, however, owned by the insurance companies, or they own the insurance company, depending on how it all works. CVS Health is the ultimate parent company over Aetna, CVS Caremark, Specialty, et cetera. Cigna owns Express Scripts. So all of whether they're keeping the rebate or not in a fully insured plan is less relevant, but in a self-insured plan that you all are managing, you want to make sure that these rebates are going to your people and to yourselves in that, and by managing your contract with these PBMs. They will all pass them through, they all will, but you have to make it, it's not their default because they want to keep the small slice that they're keeping today. As I mentioned, 48% is the average rebate across all branded drugs. It's not just diabetes. It's not just insulin. It's everywhere. So be aware of that in your plan. And they drive really perverse behavior in the marketplace. So again, this is insulin. Like just this middle column here, NovoLog, which is made by Novo Nordisk. They also have insulin aspart and rely on NovoLog. This is the same drug, same plant, same manufacturing plant going into the same vial, and they're slapping a different label on it, a different brand on it, and selling it at different price points because based upon their contract with the pharmacy benefit managers, they can't sell NovoLog less than or without the rebate that they've promised the pharmacy benefit managers. So they can't lower the price of NovoLog, but they can come out with a generic of their own medicine and sell that at a lower price point. In what planet does it make sense for a manufacturer to come out with a generic of their own drug? Only in America does that happen. We normally think of another competitor coming out with a generic. Here we've got the main manufacturing company coming out with 3 versions of their own product just so they can market it at lower and different price points. Other thing to bear in mind here, generics and biosimilars, the lowest cost drug does not always win. You need to check your plans to see if they're even covered. So new generics, and this is Medicare Part D, because this information is available publicly, but it's the same PBMs that are managing Medicare Part D that are managing your plans. So they're behaving exactly the same. New generics launched at an average of 30% savings, only 1 in 4 covered in the first year. They're not being embraced. You've got a cheaper medication on the marketplace, and they're not coming on your plan in the way that you think they would. In 2020, less than half of the generic products were on the generic tier. Now, again, we all know that you've got a generic tier for drugs, you've got a preferred brand tier, you've got a unpreferred and maybe a specialty medication, depending on, usually there's 4 tiers in your drug plan from a copay perspective. They're putting generics up there at the same tier as the branded product. They don't want your people taking the generic drug. They don't make money. The Express Scripts, CVS Caremark, Optum Rx, make less money when your people buy generics. It's just math. So look at your plan. You will find that the generic products, not all of them are on your plan at the generic tier, or they may not even be covered at all. It's bad for you. It's bad for patients. It's bad for everybody but the PBMs. You have to manage the PBMs. So let's talk about plan design options and what can we really do about all of this. So we advocate for first dollar coverage for exempting diabetes management from plan deductibles. We believe that there's a lot to be said for giving that patient what they need in order to manage their condition. And you can do that. I'm going to touch on that in a minute, but you can do that even in a high deductible health plan. Rebate pass-through, we're going to talk even further about the cost of that, eliminating list price exposure and that reverse insurance where the sick are subsidizing the healthy. We urge you to look at your generics and biosimilars, look at that formulary. If you have a third-party administrator, if you have a consultant that you're working with, et cetera, look at that formulary and see if those generics are actually being covered like generics. And are they even on your plans? And look at obesity. We're going to talk about that in a second as well. We'll cover the surgeries for bariatric surgery, which are really expensive and really invasive, but very much we're not covering anything else. And we're going to talk a little bit about that. So these are 4 very tangible things that you should be considering. So that benefit structure determines your access, determines the access to care. And these are 4 very normal plan designs, although I would submit the ones on the left are better than the ones on the right, and for insulin. So first dollar coverage, if you are giving insulin away, which many plans actually do, you could be $0, you could be $25 a month. You're going to not get many complaints. That's a very affordable cost. If you're passing rebates through, a patient can need 3, 4, or 5 vials of insulin a month. So when I talk about it, you saw the list price of the upper 200s, I rounded to 3 for the discussion. The patient needs several vials. It's not just one that they need in a given month. So that can add up to $360 or $1,200 if you're not protecting them from list price. We know that most patients will abandon a prescription if the cost is more than $250. Now, a person with type 1 diabetes is not going to abandon their insulin prescription because they will die, but they will ration their insulin, and rationing it, taking less than what's prescribed, is not in their best health interest, and it's not in your best long-term care and management and risk management interest, because rationing insulin leads to poor health outcomes. So you can see, obviously, these plan designs have a substantial impact on your people, and especially during that deductible period. So investing in diabetes management, we actually know pays off. Express Scripts, one of the 3 PBMs, last summer came out with the study that says if you cap the cost of all diabetes medications, not just insulin, all diabetes medications at $25 a month, you have higher adherence and a 16.3% overall reduction in total medical costs from diabetes due to reduced hospitalizations. You should give the drugs away, make sure they're taking them, encourage them to take it. It will save you money. An ounce of prevention is worth a pound of cure. And that is really what's coming into play here as we think about how we are spending our dollars on diabetes. And several, groups are looking at this first dollar coverage. And again, in the IRS, I just want to, on this slide, talk about there's been confusion as, am I allowed to bypass the deductible for chronic disease management in a high deductible health plan? Yes, you can. They came out a couple of years ago and clarified that in a self-insured, fully insured, HSA eligible health plan, you can bypass the deductible and go straight to a copay for diabetes management and other chronic diseases as well. So I would urge you to consider that. If you don't have that built into your plan, it will save you money. So does your plan offer first dollar coverage for diabetes management, pre-deductible? So if you would mind, clicking on here, you yes, no, maybe you don't know because you don't know your plan that well, that's fine. But if you could just play along with us here and let me know how your plans are doing this. Hopefully you're seeing that on your screen. Getting a couple of you chiming in here, so I'm going to give this a second to work its way through. You're all flipping coins. I can see in the background, everybody's flipping a coin. I'm not sure. All right, I'm going to push this forward. And so only 6% said yes. About 47, near half said we're no, and the others said we're not sure. I urge you to go take a look. I urge you to take a look. You talk about, how you can really help a patient and how you can help contain your costs. Adhering to therapy is the best way to contain cost on a patient living with chronic disease. Adhering to therapy is in your best interest, both short and long term. And your people will be a lot happier. So let's go back to rebates for a second. That's my favorite topic, guys. Rebates and premiums. Big misnomer that sharing rebates at point of sale is going to drive up health premiums. I hear this all the time. I testify in state houses on this topic. It's a misnomer. It will have almost zero impact on your premiums. We have an actuarial study looking at what this really means, and a couple things to bear in mind. And this almost zero cost increase is without factoring in medical savings by improved adherence. We just had 2 slides ago showing that you're going to save money by capping the cost, lowering that cost. We know that's real. That's not being included in this. So a couple things to bear in mind. A patient with diabetes, a patient with a chronic disease, we're going to meet our deductible almost 100% of the time. You all know that. If you overcharge that person for their drugs, you're not saving any money. There's really not much in that kitty to share with everybody else. You're simply going to pay another doctor bill that you otherwise would not have. You're paying something else. You've robbed from Peter and now you're paying Paul. No savings. It's a wash for the plan. But you've significantly increased the likelihood of one of your people rationing their drugs simply by not passing through those rebates at point of sale. Almost zero impact on the plan itself. The other way to think about this, if you think, oh my gosh, why wouldn't it drive premiums up crazily? The drug side of a health plan is the tail wagging the dog. It's 10 to 15% of a health plan. It might be higher in yours, but if it is higher in yours and you look at that, it's going to be specialty drugs that's driving that higher, not the normal branded drugs that come with a rebate. Specialty drugs don't really have much of a rebate. Generics don't have a rebate. So when you think about a normal drug spend, a drug plan, only about 30% of that drug plan spend is on branded drugs that have rebates. So it's a really finite swath of your plan that is impacted by rebates at all. And now you're only talking about the time frame while that patient's in their deductible period. So it's a really finite piece of time in here, which is why it really doesn't have much at all of an impact on overall plan costs and premiums. And I urge you to really take a look at that. And I'm going to move us to another poll question here. Is anybody passing through rebates to members at this moment in time? How many of y'all are actually doing that today? My company does. I've passed through rebates at point of sale for years. It has not driven up our costs and our overall health plan, expenditures year over year. We've been fortunate that we've gone up less than medical inflation. So, and many of you may not know, So if that's the case, obviously you pick option C and you're not sure, and I'd urge you to go take a look. But let's see where we are here. Push that out as you've gone. So not many. It's not surprising. 4.8%, 5% roughly are passing them through today. 62% say no, we're not doing it, and a third of you aren't sure. And I understand that. Hopefully you'll go take a look. But that's not surprising. And these hopefully will urge you to take a look at how your plan is designed. That's an easy thing to do, and it's not going to cost you in the short or long term. Treating obesity is less costly than treating diabetes. If we can lower the incident rate of diabetes, that patient is cheaper before they have diabetes. And so treating obesity is going to help that. So it leads to other serious conditions, type 2 diabetes, hypertension, heart disease, cancer. Many people don't realize it leads to many forms of cancer. It contributes to healthcare costs. A patient with obesity typically costs 50% more than a patient without obesity and overweight. One of the things that happened is most companies are not covering these drugs yet, and that you're following Medicare. The Medicare platform, when it came out with Part D in 2006, which was a wonderful thing because prior to that, seniors weren't getting access to medications, and the medications started getting more and more expensive, and it was really hurting seniors' health. But when they enacted that law in 2006, Congress, in its infinite wisdom, said it cannot be used for weight loss. No weight loss drugs can be covered in the Medicare program. And at the time, there were no weight loss drugs that were approved by FDA and that were effective. The weight loss drugs that were out there were making headlines was fen-phen, which is effectively speed, and it was causing heart attacks. So in the news, you were getting people having heart attacks and dying by trying to lose weight and taking drugs that had poor health outcomes. But now, in order to get these covered in Medicare, we have to make it literally requires an act of Congress, which we're working on as patient advocates because it's hard. But many of our commercial plans follow Medicare, and they're not covered by health plans because Medicare itself is not covering them. Urge you to take a look at this. I know they're expensive, so's obesity. And there are people that are at where you get in that spectrum. Obesity is one of those diseases that is a continuum, just like diabetes is from a blood sugar perspective and a body weight perspective, a BMI perspective. Those medications are cheaper than the surgery. So I urge you to take a look at that in your plan. And also behavioral therapy. A patient, back to that 525,600 minutes, I'm not going to sing to you again. So you're welcome for that. But 525,000 minutes, a patient with obesity, and it is a disease, they need help in figuring out how they can manage this from a diet and exercise, which needs to go hand in hand with these medications and the surgeries. You still have to have lifestyle management. Our plans aren't covering the lifestyle management. You'll cover smoking cessation. You'll let your people go as many smoking cessation classes as they want to go to because you need them to quit smoking. They're much cheaper if they're not smoking. We get that. We understand that as employers and as managers and administrators of health plans. We're not covering behavioral therapy. We're not covering the counseling of how to eat healthy and what nutritional guidelines they should be following. We're not covering that. And that is cheap. That, folks, is a lot cheaper than the other costs that we're talking about. So at least cover that and look at where your plan is in those. Look at your wellness programs. Look at what you are in fact covering in those areas, because most of you, I assure you, aren't covering that. And in many cases, we see behavioral therapy covered because it follows Medicare. it's only covered in a primary care setting. Well, hopefully everybody goes to their primary care doctor. Hopefully you're all healthy, but you all get your annual checkup. And if you don't, please take George's advice and go get a checkup. Your future self will appreciate you, and you need to have a benchmark for that. So go to your primary care physician. But while you're thinking about that, you go to your primary care physician. How many of those offices have you seen that has a nutritional therapist involved in there? Precious few. How many of them have somebody who can do psychotherapy and really just lifestyle management within the primary care physician office? Your plan is likely, if you cover it at all, you probably have that limitation on it. Lots of things you can think of to look at that to actually minimize the costs that you have in here as we continue to go forward. A lot of other ways that you can look to reduce risk in your plans. And we've got a handout that I urge you to download from our website that we talk about copay assistance plans. So this is where a patient, you're during your deductible period. This is often a specialty drug. And they have a $500 drug. They can't afford it. Your plan's covering it, but it's their deductible period, and it's $500. The patient goes to the manufacturer and gets a coupon. The coupon says I only have to pay $100, so they get $400 off. Your plan didn't help them do that. Your plan didn't give them that coupon. They should be getting a $500 credit for that $500 drug during that deductible period. And in many cases, that's not getting covered. Some of these plans are taking your with these copay accumulator programs and copay maximizer programs. You're taking away from the patient. What happens in these scenarios is the coupon wears off. 5 months in, the patient hasn't met their deductible, and they can't afford the drug, and there's no longer the coupon available for them. So we have another point where you're going to have a bad health outcome happen because we've made the patient pay more than they need to for it. Generic spread. Hopefully people know what that is, but a generic spread happens when the cost to the plan of a drug is less than what we're charging the people for it. So a real simple example is in a common diabetes drug called metformin. Metformin is like $4 a month at Walmart, generic. You can buy it it's not over the counter, but you can buy it at Walmart for $4. Almost any pharmacy, cash price $4. Look at your generic tier, and how many of you are charging $10 as the minimum copay on a generic drug? You've just made them pay twice what it really costs to buy that drug. Some of you might have a $20 copay at the minimum level. Now they've paid 4 times the cost of that, or 5 times the cost of that drug. Math's not my strength. That's why I'm a CFO. So these are things to really look at as far as, are we overcharging our people when especially when they're now finally taking that generic drug, which is what you really want them to do. Continuity of care, and this gets into things like step therapy. This gets into things like a patient on a stable patient with a chronic disease is best kept stable. Forcing them to change their medication due to a formulary change, that's not in your plan's best interest. Now your employee has to go see their doctor. They've got to go have more lab tests done. And the only winner in that is the pharmacy benefit manager that got an extra $1 in rebate. And at this point, that's all that's happening here. But now your patient, your employee, is not focused on their work, and they're focused on their health and trying to figure out what to do there. Other things that happen is we think about step therapy, where you force an individual to fail first. I want them to take this drug before they get to that drug, before they get to that drug. It's very common. However, your employees will be with you 3 to 5 years on average. If you have longer, that's great, God bless. But people are not staying with companies for their whole careers any longer. It is a 3 to 5 year turnover that most of us are experiencing. I've been living with diabetes for 40 years. If I go to a new employer and am forced to go backwards and fail first again on drugs I know don't work for me, that's not in my best interest, and it's really not in yours, because you now have raised the risk of me having a health problem. And you frustrated the heck out of me because, again, I'm a stable patient. I may not seem stable while we're talking here today, but I'm a stable patient, and you have disrupted the care of that stable patient. It's not in your best interest. You need to look at the pay attention to what you've got rule wise around that. Rapid approval processing of claims and of denials and of appeals. You think about, prior authorizations that are needed, and one of the key areas that happens here. And anytime a patient needs needs the drug, I mean, they've been prescribed it for a reason. They've been prescribed it because they have a condition. We see this in diabetes, in gestational diabetes, where the pregnant woman has been diagnosed and put on insulin, and there will be a block and a prior authorization before any of that is provided to her. And that's a finite period of time that patient has that problem. And you want a healthy baby and a healthy mom, and you don't want anything in the way of slowing that down. So make sure that you've got a very responsive approval process and review process for some of these things. Make sure you're covering care and education. That's something that should be covered by everybody in their plans. Also, insurance literacy. Make sure that it's understandable. Make sure that your plans, your summary plan descriptions, your materials during open enrollment are understandable for the patient. And telehealth, I probably should have put that on the top. Telehealth, during this pandemic, we all discovered Zoom, right? We all discovered these webinar programs. And again, I thank you for being with us today. Telehealth really works, and it's a little cheaper typically, and the patient doesn't miss, your employee misses a lot less work if you're allowing them to just spend an hour or 30 minutes on the phone on a web conference with their doctor versus having to leave, spending the afternoon off, getting there, dealing with the doctor's appointment, they're late, yada, yada, and you go through it. Telehealth will save you productive hours from your employees, and it is a very effective, it's not every visit shouldn't be telehealth, but it belongs as a covered area in your plans. So I'm going to pause. We're near the top of the hour, and I really appreciate everybody's. I'm not seeing a question in here, and I think hopefully we've answered some along the way as we've gone through here. So I really appreciate everybody's time in this. Please go to the slide deck and the handout from the resource widget that's available to you. The handout that I just kind of addressed, there's more information at employer. You can send us information, send us questions. You can also get to more information at diabetesleadership.org resources. So thank you so much for your hour, for your spending your hour with me. I don't take your time for granted. I hope this was of value to you, and appreciate you very much.
Thank you, George, so very much. And we appreciate you spending the afternoon with us as well and sharing all of your insights today. I know I truly, really enjoyed that presentation. I learned a lot, so I'm sure our audience did as well. And I do want to thank each of you on the line for joining us. And as George mentioned, there are some great resources and a copy of the slide deck available in the resource widget on your screen. So before you close out of our session today, don't forget to hop on in there and check those out. And as I mentioned in the beginning of our presentation today, this session has been approved for HRCI, SHRM, and HCI recertification credits. However, you must be attending this session live, so today, July 20th, in order to be eligible to receive your credit codes. Our system does keep track of all of our live attendees, and we'll be sending out an email in 24 hours, which will contain a link to redirect you to your credit codes. And in that same email, you will also receive a copy of our recording. So one more time, George, thank you so much for presenting the content today. Thanks to each of you on the line, and a huge, huge thank you to the Diabetes Leadership Council for sponsoring today's session and for their partnership. Without our great sponsors, we wouldn't have great sessions like this for you. Thanks again, everyone, and I hope you all enjoy the rest of the afternoon.
Thanks, everybody.